Okay, so it's a similar talk to yesterday, just trying to explain collagen and all the things that affect collagen. So I've just taken out as much of the medical terminology as I can. So I have no conflicts with interest with industry for this talk. So the cardinal features of EDS. So whenever you look up EDS, you'll see there's three cardinal features. That the skin has some extent of hyperextensibility. The joints are hypermobile and there's tissue fragility. Now there's many different types of Ehlers-Danlos, so tissue fragility doesn't necessarily mean skin fragility. It can mean ocular fragility. There's a couple of types where you can get globe rupture. It can be gingival fragility. There's a rare type of Ehlers-Danlos where it affects the gingiva. So there's many different types of EDS. So when I was in training several years ago, we had 6 types of EDS, and this is from Baton, a big guy in the field, him and Peter Byers. And we had 5 of them that we knew the genetics for and 1 that we didn't. We called this the hypermobile type. In 2012, they said, okay, we found a few more types. And interestingly enough, these are all problems with the molecule collagen. And then the 2017 classification came out. And the classification was an interesting idea. They said, okay, we have 12 different types. We have 19 genes causing 12 different types, because some of those genes make proteins that interact together. And so they cause the same type of Ehlers-Danlos. And then what do we do about hypermobile syndrome? Because this is the most common one, yet we don't have a gene for it. And so this group decided to make some criteria up, and I'm not sure how they came up with these criteria because they're not criteria that I would generally agree with. The criteria that they came up for with this was a mixture of features that you see in other connective tissue diseases like Marfan syndrome, with some things that you see in Ehlers-Danlos syndrome. And so the unfortunate part is that a lot of people then were told that you don't have hypermobile EDS anymore, even though you have a lot of features, and they came up with this hypermobility spectrum disorder. So the idea here from this group was, okay, let's narrow down hypermobility spectrum disorder to find a gene. If we make enough things that are specific enough, then we've got a pure population that will be able to find what gene is different from the rest of the population. But the unfortunate part is that there's a lot of different criteria in this grouping that you just have to have 5 of in the second grouping, that it's not really a pure group. So I think we will see this change in the upcoming classification. So the thing that's interesting to see about these 13 different types of Ehlers-Danlos, this is very small writing, but it's just pointing out that there's a big group of these disorders that are affecting the collagen molecule itself or how it's processed. And then all of the other types of Ehlers-Danlos are all of the other proteins that interact with the collagen and regulate the collagen. So collagen overall is the problem in Ehlers-Danlos. So the genes affected are the fibrillar collagens, and I'll tell what fibrillar means. It's sort of like where you take 3 ropes and intertwine them together, and that's a fibril of collagen. There are proteins that strengthen that collagen molecule, and they can be wrong. And then there's proteins that hold it in place, and something can be wrong with one of them. And there's different ways that you can be born with a problem with collagen. So you can be born with one gene not working, and you have too little collagen. Remember, there's many different genes for collagen. Or you can have an abnormality in the collagen protein, and what happens is it never really makes it outside of the cell into your matrix. We call all that haploinsufficiency is the big term for that. Collagen is 3 molecules together making a fibril of collagen. And although the 3 molecules could be different, if one of them's bad, it makes the whole rope bad. And then there's a whole bunch of ways that collagen is processed to make it strong. And so any one of those proteins not working properly means the collagen could be weak and could fall apart more easily. So what I'm going to do is I'm going to go through the structure of skin, so the structure of bone, the structure of the organs, all follows the same sort of principles. I'm going to talk about the role of electron microscopy, and then I'm going to talk about hypermobile spectrum disorder. Okay, so in the skin as the model, collagen gives us the strength of the skin. Elastin, as it sounds, gives us the elasticity, the recoil in the skin. And this third thing called the ground substance is all those proteins and sugars that provide the water in the skin and hold the collagen and the elastin in place. Now, it turns out that you can have an abnormality in one of those other components, and that affects the collagen as well. So Ehlers-Danlos are primarily disturbed collagen production. The morphology and the strength of the collagen is compromised. So collagen is the major protein in our bodies. So it forms our bones, it forms our organs, it forms much of the skin. There are 43 different genes for collagen. There's a different collagen in cartilage than there is in bone, a different collagens that are in bone than from skin. Some of them are the same. So collagen 1 you'll see is in bone and skin, but some of them are very different. Collagen is a rope. So the collagen fibril is 3 ropes turned around on each other. We call that a helix. And that rope has strength. And those 3 different ropes, making that one big rope, can be different molecules, or they can be the same molecule. And we see this in the skin, the abnormality in collagen, because the skin feels different in a lot of patients. And it's described in different ways in different types of Ehlers-Danlos. So in hypermobile spectrum disorder, it's described as velvety skin. You feel the inner forearm and it feels almost velvety. Doughy texture. So things like Dermatosparaxis type have a doughy texture to their skin. Vascular type Ehlers-Danlos has very thin skin. You can see the blood vessels through it. There's not enough collagen there. And then the skin is hyperextensible. So you can pull the collagen, but the elastin's normal, so it snaps back in place. So collagen is the most abundant protein in the body, and it's 70% of our skin is collagen. And so in order to get these 3 threads or ropes to go around each other, it's a particular sequence of the amino acids, so that in the center of each where they come together, it's a very small amino acid. Outside, it's a very large amino acid. And this helps the collagen molecule to bind to other things because the big molecules are on the outside of the triple helix. There's different types of collagen. So there's 43 collagen genes. So there's 2 big classes of collagen. So the collagen that makes up a lot of the skin is what we call fibrillar collagen. That means it's a rope of 3 molecules around each other, of specific length, and they're oriented all together, very well controlled. There's another type of collagen that we have in the skin as well as in the bone and cartilage, and this is called non-fibrillar collagen. They still have parts of the rope, but they have breaks in the rope, and that allows the rope to bend. So you can bend and bind onto other molecules within the matrix at those sites. So this is a collagen fiber. So a collagen fiber is made up of a whole bunch of collagen fibrils. So a whole bunch of those 3 ropes turned around on each other. And there's a whole bunch of different types of collagen in any one organ. So in the skin, this fiber of collagen contains at its core a fibrillar collagen called type 5, and it's the 5th gene of collagen. So this makes the core of the collagen. What happens here, so collagen 5 in the core, this will become important in different types of Ehlers-Danlos. And it has a little arm that stretches out at the end of it that's not processed off, and it can bind to other things in the matrix. The majority of the collagen in the fiber is collagen 1. So collagen 5, 1, and we'll see 3 look very similar to each other. They're the same length basically, and they can make this big fiber. So collagen 5 at the center, collagen 1 all around it, and then there's a little bit of this collagen 3. And so these are all 3 different types of ropes, but 3 molecules wound around each other. Collagen 3 is important because this is the collagen we first start life with. So this is our fetal collagen. And this lays down in areas where we're going to make blood vessels and forms the bases of the blood vessels, where we're going to put organs down, so where the heart's going to go, where the uterus is going to go, the ovaries. It's all collagen 3 underlying that. And then you have these collagens that are those interrupted non-fibrillar collagens. So they have areas that have the rope, but then they have all the bends in the rope. And these are called fibril-associated collagens with interrupted triple helices, but they're collagens that can bend. And these sit on the outside of the collagen fiber, and these can bend and bind all of the matrix proteins. So the center of the collagen fiber was collagen 5. It's located at the core, and it's the one that we know from classic Ehlers-Danlos syndrome. So this is the one that's affected when you have atypical scarring, this atrophic scarring or cigarette paper wrinkling scarring. Hypermobility, this is the type of Ehlers-Danlos where when you go to a Vegas show, most commonly the contortionist has Ehlers-Danlos classic type. You can have areas of the skin and the lining of the synovia that break down. It's weaker, and so this is what's called a ganglion cyst. Blood vessels are more fragile. So they're not supported as well on the matrix, with collagen 5 not working properly as the center of the fiber. And you can get very abnormal scarring patterns, some molluscoid pseudotumors, spherules, scars that end up getting calcified. And the skin is very stretchy in the classic type. So the classic type, collagen 5 mutation, it depends on where in that molecule that mutation lies as to how it affects the molecule. So there's a lot of variability. So within any type of Ehlers-Danlos, there's going to be variability across the spectrum within that one type. And that's because mutations at key sites are going to have a great effect on the body. If there's sites that are towards the outside of the molecule, it may not have the same impact on the body. So classic type is thin scars. This is the characteristic of this type. Very hyperextensible skin and hypermobility and very funny scar patterns. Collagen 3 is the fibrillar collagen that sits with collagen 5, and it's about 1/10 of the skin. And this is the one that's the fetal collagen that we started our life with. And so it's enriched, it holds the blood vessels together, it holds the viscera, and it forms a scaffold on which all of the organs and blood vessels are built. So a problem with this one gives hypermobility, but it's very small joint hypermobility only. But the big issue here is that blood vessels break very easily because they're not supported. Organs can rupture. And so this is the vascular type of Ehlers-Danlos. And depending on where in the molecule the mutation lies, the severity can vary amongst patients. So if you have mutations at one end of the molecule, you actually get a characteristic look to the person. And they often have earlobes that are very small, hollowed cheeks, and you can look at a person and a pinched nose. You can look at a person and say, yeah, this fits with vascular Ehlers-Danlos. If it's at the other end of the molecule, you don't get a characteristic facial features. So this is the Ehlers-Danlos where the skin is thin. Collagen 3 is important in making enough of the collagen molecules, and so they have less collagen overall. And this is the one where people can have strokes, heart attacks, organ rupture. Collagen 1 is the majority of the collagen in the skin. So 5 was the center, 3 a little bit throughout, but important in forming organs and blood vessels. And then collagen 1 is the filler. It's the most abundant collagen. And there are 2 genes that make this protein. So one gene being bad and making a bad protein can affect the whole thing because those 3 strings thread together. It's the best studied of the collagens because it's the most easily produced collagen in tissue culture. And there's a lot of diseases that are caused by mutations in collagen 1. And so this disease is osteogenesis imperfecta. There are groups of patients with collagen 1 mutations that have blue sclerae as a marker of this. But there are many types of Ehlers-Danlos that are also caused by collagen 1 mutations. So arthrochalasia type is characterized by congenital hip dislocations as a marker of it. Cardiac valvular type is when the second gene has been affected and it screws up the whole collagen molecule, and characterized by problems with primarily the mitral valve, but all the valves in the heart can be a problem. There are rare variants of classical and vascular type that are caused from severe mutations in collagen 1. And then osteogenesis imperfecta. So most of the OI patient population have mutations in collagen 1. It's like Ehlers-Danlos. There's a whole bunch of supporting things around the collagen that can be mutated in OI as well. And then we have seen patients that have features of osteogenesis imperfecta and Ehlers-Danlos. And this is the OI-EDS overlap. That's due to the second gene of collagen 1. So collagen 1 is the filler, collagen 5 is the center and regulates the collagen, and collagen 3 is the fetal collagen and holds our organs and blood vessels in place. So collagen goes through many different levels of processing within our body and within our cells before it becomes part of our skin or part of our bone or part of our cartilage. And some rules in general with collagen. So at a gene level, if you have lots of vitamin A around, lots of vitamin C, if insulin is at a high level, you make a lot of collagen. You make less collagen if you're on steroids, and so steroids are well known to cause atrophy, and that's loss of collagen. And inflammation causes collagen to be downregulated, to make less inflammation. So there's inflammatory cytokines like tumor necrosis factor alpha, interleukin 6, interleukin 1. These all cause collagen to go down. Within the cell, when the cell decides it's going to make some collagen, so what it does is you have DNA that encodes those collagen, and you make a message from that DNA and you send it into different parts of your cell to make it into a protein. And there's a whole bunch of other proteins that help make that into a protein. And if any of these proteins are wrong or don't do their job correctly, the molecule isn't made properly. And so this is a type of Ehlers-Danlos where one of the proteins inside the cell isn't working properly, just to change the side that the collagen faces on. And so here you can see atrophic scarring, umbilical hernia, hypermobility. And this is FKBP14 related Ehlers-Danlos, a rare Ehlers-Danlos, but this is just because one of those proteins doesn't twist a molecule on the collagen when it's being made into a protein. And it has repercussions in many different organ systems when that doesn't work. Because remember, collagen is in many different organs. So you get kyphoscoliosis, myopathy, joint hypermobility, even hearing loss. Within the cell, there are many other things that have to happen to the collagen molecule. So it has to get sugar on it. Sugar helps control the pH and the stickiness of the collagen. It has to get hydroxyl groups on it. And these are things that will help later bind collagen together. When these are wrong, you get another form of Ehlers-Danlos. So this is just because a particular amino acid is not being hydroxylated, so it can't bind later on with other collagen molecules. And this is kyphoscoliotic type of Ehlers-Danlos. And this is a type of Ehlers-Danlos that prevents with progressive kyphoscoliosis, but this is the one that also affects the eye. So you can get retinal detachment more commonly in this, globe rupture. So these three fibers of collagen are put together inside the cell, and they're modified within the different compartments of the cell. So this is our cell biology. So the collagen molecules are all wrapped up into that triple helix. They go out, and they need to get processed as they go outside of the cell. So there's ends sticking off at one end and another end sticking off at the other end that have to be cut, and then they have to be lined up together and then consolidated. So if you can't cut off the ends of the molecule, then you get another type of Ehlers-Danlos, and this is Dermatosparaxis type. And Dermatosparaxis type, because you didn't cut off the end, the collagen molecules don't come together properly and they sheet apart very easily. And so Dermatosparaxis type is characterized by easy wounds. So the skin can just shear off. Another type is where the collagen molecule itself, the gene, had a mutation, and where it should be cut, there's not a site for it to be cut. It's not marked. And so, like Dermatosparaxis type, it doesn't hold together properly, but it doesn't shear off as easily as Dermatosparaxis. So in this type, the hips don't form properly, surprisingly, and you get bilateral congenital hip dislocations. You have severe joint laxity, hypotonia, so usually they pick up these patients as a baby because they present very floppy, they have no muscle tone. So in the making of collagen, collagen 5 was at the center, surrounded by collagen 1, which was the filler, and collagen 3, which is throughout the molecule, but the fetal collagen. And then there's all these other collagens, 12, 14, that sit with the molecule and help bind it to other things. And there's a type of Ehlers-Danlos that was recognized in the last 10 years where it was one of those other collagens, collagen 12, that's not working properly. So that's one of those ones that used to bind to all the other proteins in the matrix. So these all link into the ground substance and the elastin. So collagen is in our skin to give us strength, elastin gives us the snapback, and ground substance gives us the texture. Elastin interacts with collagen. So when there's a disorder with elastin, you can usually see an effect on the collagen. So elastin gives us the resilience, the snapback quality of the skin. It's tied to the collagen by the ground substance. And there's a whole bunch of proteins that link the two together. Defects in elastin give us many different disorders, Marfan syndrome being a very famous one, cutis laxa being where you don't have enough elastin, so you have no snapback, so everything just sags. If some of the cofactors for elastin aren't present, like copper, then elastin doesn't form properly and you get syndromes like Menkes. The ground substance is all that stuff in between elastin and collagen and linking it together. So these are about 50 to 70 different proteins, probably about 50 different growth factors that sit in the matrix, and a whole bunch of sugars that hold water within the matrix. This is just a schematic showing that there's a whole bunch of different proteins. They all have different names. And the interesting part is that we're seeing that some of these proteins are being described as the very newest entities in Ehlers-Danlos because they have an effect on collagen. So this is where one of those proteins doesn't work properly. It doesn't get its proper sugar. So you can see hypermobility, and you can see an abnormality of the chest where it looks like a pigeon's breast called pectus carinatum. And this is musculocontractural EDS. And so this is where one of those sugared proteins that helps bind to the collagen just doesn't get its proper sugar. And so it doesn't bind the collagen properly. And you end up with muscle problems, skin hyperextensibility, you get fragility of the skin like you see in Dermatosparaxis, and you get bony deformities. And so remember, this is just a sugar not being properly processed on a protein. And what you see here, this is electron microscopy, a first introduction to EM. These little lines shouldn't be straight lines. So what's happened to this protein is that it's making a straight line between the collagen and it's not holding the collagen properly. This is a person who's unaffected, where it's more curved lines around the collagen. So you can see on electron microscopy the abnormality that comes up here. This is Ehlers-Danlos type 14, so not in the classification system. And this has features of vascular type in that you look at the person's chest in D here, and you can see that the blood vessels are right up at you, that the skin is thinner. They have atrophic scarring that you can see over the knees there, so sort of like the classic type. And then they have pes planus, very flat feet, fallen arches here, but they're not fallen because they never developed. So as you would see in several types of Ehlers-Danlos, including hypermobile spectrum. This is called ABP1 related, classical-like Ehlers-Danlos. So it's a brand new variant that's just been described in the last year and a half. And it's a protein that is in the ground substance that's important in binding to the collagen fibers. It's important in blood vessels, lung, and bone as well. And so you see features of vascular, features of classic type, and something new. You see osteoporosis, which is not that common in the other types of Ehlers-Danlos. On electron microscopy, so a control patient who does not have Ehlers-Danlos or connective tissue disease is at the top, and you can see all the collagens look the same size, about the same space apart. In the bottom is one of these patients with this proteoglycan abnormality, and you can see that collagen size starts to vary. You get some large collagens, and the spacing is different. So Ehlers-Danlos syndrome, fibrillar and non-fibrillar collagens, so collagen 135, collagen 12, which was one of those non-fibrillar collagens, enzymes that process the collagen within the cell or outside of the cell. All of these proteoglycans or proteins with sugars that link the collagen and the elastin together. And so this is where we're probably going to find the majority of hypermobile spectrum disorder genes lie, because there are many of these different proteins, and it's going to be important to try and narrow down the features in a group of people as close as possible to define a group that are genetically different, and that way you'll be able to find a gene for a particular type of hypermobile type spectrum. And we're probably going to find that there's 25 or 30 different genes causing hypermobile spectrum disorder. The role of electron microscopy. So normally collagen synthesis is tightly controlled so that those molecules are nearly identical to each other and spaced similarly apart. We call it a periodicity of collagen. When you look at it under electron microscopy in longitudinal section, it's 67 nanometers between collagen molecules. Inherited disorders of connective tissue, so whether this is Ehlers-Danlos, whether it's Marfan's, whether it's Loeys-Dietz, they all have abnormalities that you can see in the collagen. And you can see this when you magnify the skin 100,000 times to 500,000 times. And so how we do this is we take a biopsy from a sun-protected site. And the reason for this is because the sun damages elastin and it makes things look a little bit abnormal. And so if we take it from a sun-protected site, like the upper buttock or the inner upper arm, we fix it for electron microscopy, and we can assess the proteins directly in the skin. So this is what a person without an inherited disorder of connective tissue looks like on electron microscopy. So the top is showing you collagen molecules in longitudinal section. And you can see there's these little lines because every collagen is lined up properly. In cross section is the lower part. And you can see all these little circles that are all the same size and relatively same distance apart. Now, if we compare this to what happens in inherited disorders of connective tissue, in classic Ehlers-Danlos, you see these huge collagens. So you can see collagen spacing is a little bit abnormal here. These huge collagens we call collagen flowers because they look like a big flower opening up, or dysmorphic collagen. Vascular type Ehlers-Danlos, it's not as dramatic, but what strikes you about this is there's less collagen. So this is where collagen 3 is not working properly. And you do have variation in size and shape of the collagen. Dermatosparaxis, Ehlers-Danlos, so this is where you couldn't process the collagen properly and it rips apart easily. Doesn't look like collagen under electron microscopy. So they call this hieroglyphic collagen. Hypermobile EDS mimics classic type EDS on electron microscopy. Not as prominent usually, but what we see is we see these collagen flowers and interruptions in the spacing. And the other interesting part in hypermobile type is sometimes you see problems with the elastin. So this is where the elastin has been calcified. We don't typically see that in classic type Ehlers-Danlos. So when can electron microscopy be helpful? So any abnormality of collagen, so inherited disorders of connective tissue. So when you affect a protein in the matrix or the elastin, it affects the size of quality of the collagen as well. So we see these abnormalities in all of them. It's not specific to Ehlers-Danlos, although different abnormalities do favor certain types of Ehlers-Danlos. There are other problems where we see collagen abnormalities that can be acquired. So if a person has very bad diabetes, they sugar their collagen and their collagen can't be broken down properly. So you do see large collagens, but they don't look like flowers. They look like very large normal collagen. And then there's some very rare things where the body has stimulated the fibroblasts to make abnormal collagen. So scleromyxedema, nephrogenic fibrosing dermopathy is something that's a side effect of people who get an MRI from the gadolinium in the MRI. If they have renal problems and they can't clear it, it causes their fibroblasts to turn into wound cells and they try to make a whole bunch of abnormal collagen. Now, hypermobility spectrum disorder. So everybody knows the Beighton scale score. So problems with this. So one of the criteria is piezogenic pedal papules. These are very common in the population. So 40% of people have piezogenic pedal papules. That's not a good one to add on when you're trying to delineate a narrow disease focus. So it's a hypermobility spectrum disorder is probably many different genes causing it. It's an autosomal dominant. It runs through half the family. There's probably an influence from hormones on the expression of the genes or the modification of the collagen, as some of the severity is much more severe in women than it is in men. And as of menopause, things seem to get better in women. The features, so generalized joint hypermobility. So we use the Beighton score as the criteria for cutoff, but if a person doesn't have a 4, 5, or 6 out of 9 on the Beighton score, then we have to look at the other joints as well. Are they hypermobile in different joints that aren't assessed by the Beighton score? Chronic joint and muscle pain. A lot of people are told they have fibromyalgia. I don't think this is fibromyalgia. I think it's coming from the proprioception problems in hypermobility spectrum disorder. It's more of around the joint pain than in the joint pain, and it's not really a fibromyalgia type of pain. Recurrent joint dislocations or subluxations, symptoms of autonomic dysfunction, which we call dysautonomia, because it probably affects many of the different nerves within the skin, the joint. Easy bruising is very common. You don't see widened atrophic scars in hypermobile spectrum disorder. If you see those, you have to think about one of the other types of Ehlers-Danlos. Gastrointestinal disorders. Now, whether this is from mast cells or whether this is from abnormal Purkinje fibers or the innervation being different within the bowel. Small fiber neuropathy is very common, that you don't see as many nerves if you take a biopsy from the leg, for example. Mast cell disorders are very common here. There's a lot of debate in the literature because some people don't accept, some experts in allergy don't accept mast cell activation syndrome. Mast cell activation syndrome, how it's defined, is people who have anaphylaxis. I think that's one end of the spectrum. I think that everybody, or in my experience, I've probably seen about 300 people with hypermobile spectrum disorder, and I would say 90% have an abnormality with mast cells, be it from simple flushing and dermatographism. Dermatographism is where pressure causes the mast cells to degranulate. So if you stroke the skin, you see a hive coming up afterwards. It can be very disabling when it's very severe dermatographism, because a person lying on one side in bed, all of a sudden they're getting itchy on that side because all their mast cells are degranulating. So they move to the other side. That side gets itchy. And so I think that there is an abnormality within the mast cells within hypermobile spectrum disorder, and that this behaves like an inflammatory disorder in many patients. And there is data to support this. So there's no single gene to date in hypermobile EDS. You can have hypermobility. Tenascin 10 was a candidate at one time, but then that's sort of its own type of Ehlers-Danlos. We know that it could be any one of these components, but the likely one is that it's one of these proteoglycans because there's so many of them. So there's a group who's been doing some really quality research in Ehlers-Danlos, and this is a cell biology group. And they've got 3 publications out looking at different aspects of hypermobility spectrum disorder and Ehlers-Danlos hypermobile type. So their feeling is that these 2 are one and the same, and that they're different from controls and different from other types of Ehlers-Danlos, including vascular type and classic type. And this is what they compare to. So when you look at the matrix within skin from hypermobile spectrum disorder and hypermobile EDS, there are different proteins that are expressed on the cells. So the fibroblasts are the cells in our body that make the collagen, at least in the skin. And so when you look at what proteins these fibroblasts are expressing, it's different than the proteins in people who don't have hypermobile spectrum disorder. So their anchoring protein is an anchoring protein that we see typically in wound responses. There are a whole bunch of inflammatory mediators that these fibroblasts are making that, again, are not seen in other types of Ehlers-Danlos and not seen in controls. The fibroblasts are differentiating along the lines into something called a myofibroblast, which is a cell that tries to contract the collagen together. It's one that we use in a wound response, so that the fibroblasts are not normal in hypermobile spectrum disorder and hypermobile EDS as compared to controls and other types of Ehlers-Danlos. So this is really quite exciting research that they're doing, that they're finding that, yeah, this is behaving like a wound response / inflammatory disorder, even at the molecular level. A normal matrix, so normal meaning that there's not an abnormality in the collagen. So you've got to think that when we're forming, all of our organs, all of our nerves, all of our muscles, they follow the matrix. They're guided along the matrix by proteins, by growth factors. If your matrix is abnormal, things may not migrate properly. And you think about this when you're thinking about, okay, functional gastrointestinal disorders. Have the nerves not migrated properly? Small fiber neuropathy. So is there an abnormal effect from the matrix that starts right from birth? Nerves are intimate with the matrix, And could these be upregulated by the wound signals? So a lot of the pain in EDS that we can't explain, that's called fibromyalgia, is this really more of a wound response or an inflammatory response? So when we look at management of EDS, remember that the upregulated things that upregulate collagen were vitamin C and vitamin A. So that's why you say go crazy with vitamin C, don't go crazy with vitamin A, just a little bit, because vitamin A causes hepatotoxicity with too much of it. Avoid steroids where possible, protection from trauma, avoid contact sports, as we've heard today. Avoid aspirin because you have a tendency to bleed more easily because the blood vessels aren't supported as well. Surgery, if there is a problem with bleeding, most people respond to tranexamic acid. It's just a way to try and clot more quickly. Suturing wounds, double layers, closure, leave them in longer, usually twice as long as you normally would. Steri-strip wounds or give additional support to them. And now the mast cell phenomena. So mast cell stabilization, there's many ways we can go. I think that there is an inherent problem with the mast cells. Mast cells are a matrix cell. They come, so mast cells aren't made as mast cells, they're made as basophils in the bone marrow. They come out to the skin, they go into tissue, they're in the gut, they're in the skin, and then they differentiate into what we call mast cells, and they're resident within the tissue of the skin and the gut. And there's a little variation on the differences in mast cells between the gut and the skin. They express a couple of different markers, but they're basically the same cell type. They have lots of granules in them. They have lots of things that they express. Mast cells in skin are important in a lot of skin diseases because they magnify the immune system. So what happens is you can have an autoimmune disease, but you don't get the disease if you don't have mast cells, because mast cells recognize things like complement being split, they bind to it, and then they attract all of these inflammatory mediators like neutrophils, other mast cells, and eosinophils. So skin is a good model in mast cells because we know they're important in a lot of different diseases. And there's lots of different ways to try and prevent mast cell stimulation. So you can try and stabilize the mast cell. And these are things like cromolyn and ketotifen. You can try to block the end result of a mast cell. So antihistamines block histamine. Aspirin would block leukotriene. So mast cells create a lot of different things. There's some antidepressants like mirtazapine, which would block serotonin, which mast cells release. And then you could also try to block mast cells from being active, from having them move within the skin. And there's things like colchicine that can be used to inhibit mast cells from moving around. And then you can try to block stimulation of mast cells by IG by things like omalizumab. So what I've tried to do is go through explaining the abnormalities with collagen, that anything in the matrix can affect collagen. Electron microscopy can detect abnormalities in the matrixal structure and support a diagnosis of an inherited disorder of connective tissue. And that hypermobility spectrum disorder, as we're learning in the last year and a half, has changes in the matrix that likely exert effect on both the migration and the activity of other cell types. Questions?